Good afternoon, good evening, good morning. My name is Simone Carter. I'm the lead for Integrated Outbreak Analytics for UNICEF's Public Health Emergencies team. And I also manage the Integrated Analytics cell here in the Democratic Republic of Congo. And I'm here to provide a training on what it's like to engage with Integrated Outbreak Analytics. And so this training, let me just hide that, there we go. So the objective of today's training is really to provide you with a history of Integrated Outbreak Analytics and how it works, give some examples of how it has operated in practice and what's made it successful. There are additional videos that will be made available online. You can also access the IOA network group videos on our YouTube channel or access more information through email and chat. So the history of Integrated Outbreak Analytics. And so it's really at IOA is an in-country initiative for country-led response. So in September 2018, at the beginning of the 10th Ebola outbreak in Eastern DRC, the Social Sciences Analytics Cell, or the CAS, and the EPI cell were both set up at the same time to respond to the outbreak or to provide better understanding of outbreak dynamics. And that approach was actually viewed as quite positive. And so the Minister of Health signed terms of reference to be able to systematically conduct operational research to better understand and support outbreak response. So the integrated cell started systematically informing the response by March 2019. And what this meant was that the epidemiology cell and the social sciences analytics cell were sitting together and looking at the different outbreak dynamics and then looking at what information was required to explain the outbreak, collecting that information and providing analysis to response teams at different locations in real time. In 2020, the Welcome and FCDO grant came into UNICEF and Born Research to be able to model the approach for future outbreaks. And very shortly thereafter, we had COVID, and IOA was scaled up to look at the broader impacts of COVID-19 in the DRC and to support greater analysis at a global level. So that also meant setting up an Integrated Outbreak Analytics working group under the Global Outbreak Alert Response Network, or the GORN network, growing the project really outside of the DRC. It was also set up to respond to other public health, the screen switched, to other public health emergencies, including the plague, cholera, and Ebola. There was an IOA core team that was set up under the Global Outbreak Alert Response Network shortly thereafter to be able to have a partnership of different actors working on the project moving forward. They were also able to deploy, so via GORN and partners, we were able to deploy to Guinea in the 2021 Ebola outbreak to set up and replicate a similar type of IOA cell as had been done in the DRC. The approach was published in October 2021. There's been core team support to the EVD response in Beni in the DRC and also in the end of 2021. We've got terms of reference to work at a global level, providing country support. We have a publication that comes out quarterly called the IOA Field Exchange, which gives an opportunity for different country partners, be they Minister of Health, national and international NGO workers, working on any kinds of IOA approaches to be able to document and share those practices. We continue to have IOA network calls focusing on different methods, bringing in different partners, and supporting countries in Sub-Saharan Africa and now as well in Latin America. So what is Integrated Outbreak Analytics really? So Integrated Outbreak Analytics is about bringing different pieces of data together. So first of all, that might be programs data. So when we talk about programs data, that could be, for example, the number of infection prevention control kits or wash kits that have been distributed to healthcare facilities. It could be the vaccination of the particular disease that we're looking at in that data, but it could also be things like cash transfer activities, which might improve healthcare seeking among people during an outbreak. It also, of course, requires surveillance data. So this is the who, what, and where, the number of cases, the sex of the cases, the location of the cases, and the disease. But we also want to include healthcare services use and health outcomes. So this could come from health information systems, DHIS2. It could include things like healthcare services use. It could talk about other diseases in the area. So are there things like malnutrition rates or measles, malaria that might already be existing in the area, making communities or particular groups more at risk? It's also important to understand what is the routine engagement with vaccination before the outbreak started. We also find it critical to include community perceptions and behaviors. And this will tell us, particular risk behaviors, but also preventive behaviors and how people might seek care. And that data is collected from household surveys or qualitative interviews. And while we recognize that healthcare workers are, of course, community members, in an outbreak, it's really critical to understand their perceptions of risk, their perceived ability to stop disease transmission in their center, their ability to communicate on a disease or disease prevention or detect it as well. And so we get all of this data, and that's fantastic and lots of information provided. But we also need to look at this within its context. And this means understanding things like the different events or policies that have taken place over time. Were there border closures or were there school closures? We want to look at price trends. So did the cost of transport increase, which could have an influence on healthcare seeking, or was there population movement as a result of either displacement or conflict or any kind of extreme weather conditions or season? And all of this is also really important to understand in social and gender and cultural norms. So what are the practices? Who makes decisions for healthcare seeking, for vaccination? Who is responsible for safe burials or burial practices? Who's responsible for caring for the sick? So all of that kind of information is really critical as well. So we can look at the situation holistically. And so we collect all this different data. Some of it might be already existing, and some of it we need to identify gaps in the information needs and then collect it for us to understand the whole picture. And so this is an interview with Matias Masoko, who is the head of the Integrated Analytics cell for the different Ebola responses, and also works as the cell manager at a global level, at the national level, sorry. And he is talking about the transdisciplinary approach.
En fait, la cellule d'analyse, normalement, il a deux parties. Il y a la partie épidémiologique et la partie sociale. Et cette dimension a ajouté à l'analyse du côté épidémiologique la compréhension et la perception de la communauté, la perception des prestataires a aidé à mieux comprendre la situation épidémiologique par rapport aux acteurs qui sont sur le terrain et par rapport à la communauté par rapport aux personnes qui sont en train de récolter. Et ça a été une contribution pour bien comprendre la situation épidémiologique à sa globalité.
And so integrated outbreak analytics, it's not just about evidence generation, it's really about evidence use. And so when we get our research question or our analytics question, it comes from either a change in the epi situation, a new number of cases in a new location, but there might be a request from commissions, pillars, different actors in the response. We might have existing data that leaves us with a question. So for example, we see low rates of participation in infection prevention control training in one area or another. There might be a shift in context, so an increased population movement or increased rains. So we have a question that we need to be asking. And so when we do that, we will develop quick terms of reference. So these can be 1 page maximum, but what we want to make sure in those terms of reference beyond the methodology is how are we going to use the data? So can we ensure that data will be used before we collect anything new or put teams to work? And so we'll very quickly validate the terms of reference by the coordination, pillars, different actors who are going to be using the data. Then we collect any additional data that is required, and we bring it together with an integrated analytics lens. So we'll bring in all those different data pieces that we talked about previously, or as many as that we can find, and we'll sit and look at that holistically. So seeing what are all the different push and pull factors that can explain a particular context or respond to the question. And so That's wonderful information, and it tells us, hopefully it will tell us about what we're seeing in the disease or the behavior or the health outcome. And we'll present that information to multiple actors. So we might present it to community healthcare workers through a discussion or a meeting. We might present it to local NGOs or international NGOs as well. That might be through a PowerPoint presentation. We'll present it to Ministry of Health actors. So one kind of analysis might be presented at multiple levels. And it's really important that we present that back to communities as well. But the critical part of this is co-development of recommendations. So as we say, we don't want to start a study unless we can show how it'll be used. And we want to make sure that everybody's participating in the recommendations. And what we do then is track the recommendations by study or by location and by actor who has agreed to implement those actions over time. So we agree on indicators and we can follow those up over time. And we do have additional trainings available online if you'd like to know more about the tracking use of recommendations. We call the tool Bonito. It's very easy to use, but it does help everybody see how much we are actually using the evidence. So we think about IOA partnerships. So an example of the partners in the DRC. So IOA, as we see, it's not about one logo, one branding. So we look at these are all the different partners that have been involved in looking at the broader impacts of COVID-19 on communities and community health in support of the Ministry of Health. And so the different data collected, it might be, as we said, surveillance data, programs data, DHS2 data. Some actors might be better at analysis, or they might be doing a specific smaller study on measles in one location by Epicentre, but the INRB might be doing another one. And we can then use ACF, who has program data, and Médecins du Monde, who has healthcare behavior data, and bringing all that kind of information together at one location. Bringing all those actors together at one location can really help us adapting strategies and activities, redefining our priorities, implementing new strategies or programming, but also doing advocacy for changing in strategies or financing new projects. But again, all of this is really done through an integrated transdisciplinary approach with an aim to support evidence-based decision-making in near real time. And so when we think about the IOA partnership at the global level, the idea is really to promote and strengthen a transdisciplinary understanding of outbreak dynamics for improved, appropriate, and more accountable response. And we really seek to provide adapted context and country-specific support. So it's not about a one-size-fits-all. It's about saying, what data does exist? What are you able to use? What are you able to collect? And what do we want to know to support better decision-making in real time? Recognizing there's information that is nice to know and need to know. And so really prioritizing the need to know and how we can collect that in the most appropriate and accountable way. We really facilitate using a community of practice where IOA experiences can be shared and capitalized and used to support partners in their adaptation and application of multiple outbreaks and contexts. And so, as we said, this is really, an in-country initiative and for an in-country, for a country-led response. And this is an example of the Red Cross partners using the data provided by the IOA cell in the DRC for cholera.
S'appuyer sur les résultats de leurs recherches afin de renforcer les messages auprès de la communauté à travers tous les moyens de communication que nous utilisons. Je cite par exemple la fois passée, les résultats de leurs recherches nous ont permis à mettre en place un système de production de vidéos pour renforcer les messages de sensibilisation à travers les réseaux sociaux, à travers les radios et
And another example of how IOA was used to better understand the risks of children from Ebola is from Gaffer Gomina, who is the response coordinator in the 2021 Ebola response in Beni in Eastern DRC.
La cellule d'analyse intégrée nous a en fait montré que les décès des enfants sont dus au fait que les enfants n'arrivent pas en fait à manifester des signes lorsqu'ils sont malades. Ces petits enfants, ils pleurent et les parents, les femmes les prennent, les amènent dans les structures de santé. Lorsqu'ils n'ont pas satisfaction, ils changent beaucoup de structures de santé. Donc c'est le fait de changer les structures de santé avec le manque de mesures d'hygiène qui font que les enfants se font contaminer. Et lorsqu'ils sont contaminés, malheureusement, ils décèdent rapidement. Donc cela nous a amené à changer notre stratégie en matière de communication et d'engagement communautaire et à accentuer l'activité
And so our last presentation that we have is an example from Dr. Jacques, who is an integrated outbreak analyst and an FETB training, and how he worked with setting up the cell for the first time during the during the Ebola response in Guinea in 2021. And so just when we think about IOA and you know, we explain kind of the approach, there's or the methods used or the data used and the process of it, there's also different approaches that can be used as we aim to be as flexible as possible. And so the approaches that have been used in the DRC, for example, to date, are having, first of all, an IOA cell. So this is what we've seen with Ebola, for example, or COVID-19. And this is really about, it's implemented or set up during a high risk or larger scale outbreak. It's when we have often incident management system in place. It's a full-time focus. There's different pillars. So for example, WASH IPC, risk communication, community engagement, surveillance, vaccination. And we're all working together with meetings every morning. There's rapid data collection, analysis, and processing, and sometimes we can have presentation of data even as little as 48 hours later. We also have used IOA with recurrent outbreaks. So this is, again, an IOA data approach. So looking at socioeconomic data, health information systems, surveillance, epidemiological data, qualitative data. And it's really about aiming to understand underlying factors. Again, we work on the co-development of actions. So the process is the same and the data sources and methods are the same. But as opposed to having everybody working together on one single disease, we might go to a particular location and work at bringing the different actors together to talk about a particular disease in that location, but outside of a formed system for that disease. And so, for example, we might do that with measles. A third approach is really looking at integrated early warning. And so this is about using, we might have SMS alerts for early warning on disease, systematically though as well, using the health information systems or DHIS2 data, using community and other reports, and having that as an early warning and trigger. So as opposed to using just one early warning format, using multiple different data types and sources to be able to better identify risk and respond to that quicker. And in terms of the response, the fourth approach is really looking at integrated outbreak analytics in surveillance or investigation teams. So often we send a first investigation team and they're very biomedical or field epidemiology, and they might have some great experience looking at the disease itself. But what they might be missing is factors that are socioeconomic or gender, culture norms, not having access to the health information or DHIS2 data beforehand to understand what are the other trends in diseases in that area, what are the other vaccination rates for other or routine vaccination in that area, what are other factors that might be occurring that might cause a spike in that disease at that time. And so really working with those rapid investigation teams to have a more holistic lens during that investigation period. And finally, we use IOA as well on specific themes. So it might be just one particular question about an outbreak or a health concern, and that would be using an IOA lens. So recently we've talked a lot about COVID-19 and vaccination, and a lot of the studies really focus just on vaccination uptake. But when we talk about an IOA lens, this would be considering things like what is routine vaccination, what broader impacts have COVID had on routine vaccination or other healthcare services use, or what impacts have it had on socioeconomic, or what socioeconomic impacts have it had, which might limit transportation capacity or increase cost of transportation, thereby hindering people's ability to go and seek the vaccine. And so there's a word that, are we looking at factors such as people having side effects, which would make them not be able to work the next day, and that would make them not be able to earn money, not be able to feed their families, etc. And so really applying an IOA lens, going, what is the perception of risk? What is the disease prevalence in that area? Do they even have cases? And then understanding all the other factors that might influence that particular health outcome or health behavior. And so those are the 5 approaches that we've been using to date. Of course, there might be others that we will be exploring in future. And so just, when we think about why did this approach work? So we did have, as we mentioned, this evaluation and modeling process done, funded by Wellcome Trust and FCDO with Gordon Research and UNICEF. And so the factors that really demonstrated the success, the first was about inclusivity. And so really understanding that at all phases of any kind of study analysis, the different data users were involved. So if we're looking at work with healthcare workers and we want to understand healthcare worker behavior perceptions, we want to involve those working in healthcare or those working in infection prevention control, making sure that we're asking questions in ways that are usable for them. It's also about a field and service-based approach. So we're addressing questions that people are asking for. We're not coming back and making up our own questions, but we're really trying to work with response actors or healthcare workers or different NGOs, Ministry of Health, to say, what are the information that you need? What is the methodology that will allow you to use that information? And really asking each time, are we doing this in a way that can make sure that the data is used? The third is about having adaptive approaches to information sharing. So it's not about a one size fits all. Some people need one-to-one sessions. Some people want it in email. Some people want it in PowerPoint. Some people want a brief before we do a PowerPoint. And so we've really learned about adapting these local languages, different presentations, different ways of communicating results for the co-development of recommendations. So every time also when we do presentations, starting off by saying the objective of this is to be able to identify solutions with indicators and people responsible that we will follow up with later. And so that brings us on to that co-development of actions recommendations. So of course, we can never remove power imbalances, but we do seek to be as inclusive as possible. And so that means that it's not just about the decision makers at a high level, but making sure that community healthcare workers, community groups, civil society are involved in suggesting and co-development of recommendations. And while they might not be able to have the funds or the actions, we can support them in bringing those recommendations to different actors to take action. We also make sure that the research teams have experience in programming, so they are actually able to engage and speak a programming language to better use the data as well. So, and last is that it's really about, no branding, no egos. And so we do our best to have either all of the different actors' logos involved or none, and having really neutral branding, as you see in this presentation and all of our different publications and work, is that it's about having everybody feel that they can contribute and then they can take the data away and also use it. We want different partners to take the results and the reports and the studies and be able to also seek funding to facilitate evidence-based programming. And so by having this kind of neutral branding, that really does facilitate the approach. Finally, we don't run a study or collect data if somebody else has. So we really try to promote the use of each other's data and see what information that already exists can be replicated and used and promoted, as opposed to each time coming in and saying, I need to collect this new, etc. And so this is an example. So this is, again, the IOA cell team in Beni in 2013. So these are the same colleagues that we've been working with since 2018 in the DRC, talking about it being a real, in-country and reinforcing in-country capacity.
Il y a les contextes, il y a les discussions très la réunion nationale et tout cela peut alimenter la bonne utilisation de la il faut renforcer la capacité des différentes personnes.
So Matthias just really highlights that really important part of having people physically in country. We get a lot of remote support as well, but without those people physically in country, we're not doing long-term capacity building of the different partners here in the DRC or in another country where we might be working.
Pas seulement voir les données collectées pour les analyser, mais aussi comprendre le contexte. Et travailler ensemble avec ceux-là qui produisent, qu'on puisse faire une restitution à ceux-ci, puissent apporter leur contribution par rapport à donc, il est vraiment important que cette cellule soit logée pour qu'elle soit là où il y a le problème. Voilà, et c'est comme ça.
And so that's everything for the training today. We of course welcome you to be in touch or to find out more about the different trainings. Please don't hesitate to send us an email or to link into our website or other videos. And we're happy to support as we can. Thanks very much and have a great day.